Today, we are going to walk through the clinical examination of neurofibromatosis type 1, or NFON, in a way that mirrors how you would approach a real patient, step by step, connecting visual clues, systemic findings, and diagnostic reasoning into one clear picture. Imagine a young patient standing in front of you, and before you even begin asking questions, your eyes start picking up subtle but highly characteristic features. NFON is one of those conditions where the diagnosis often begins with simple observation, if you know what to look for. The journey starts with the skin, because the skin often speaks first in NFON. You notice multiple light brown patches scattered across the body, smooth-bordered and evenly pigmented, known as café-au-lait macules. These are not random birthmarks. They are one of the most important early clues. The number and size matter. When there are 6 or more of these macules, especially if they are larger than 5 millimeters in children or 15 millimeters in adults, they strongly point toward NFON. These spots are often the earliest sign, sometimes present even in infancy, quietly indicating an underlying genetic condition long before other features appear. As you continue examining, your attention shifts to the folds of the body, particularly the axilla and groin. Here, you may notice clusters of freckles in areas that are not typically sun-exposed. This is known as Crow's sign, and it is highly specific. Unlike ordinary freckles, these appear in intertriginous zones, and their presence adds another important piece to the diagnostic puzzle. Now, as you move your hand gently over the patient's skin, you may feel soft, dome-shaped nodules. These are cutaneous neurofibromas, and they have a very distinctive feature known as the buttonhole sign. When you press them, they seem to sink into the skin and then reappear when you release pressure. This tactile finding is almost pathognomonic and gives you a direct sense of the underlying nerve sheath origin of these tumors. Some patients may have only a few, while others may have hundreds, increasing in number with age. As your examination deepens, you begin to explore beyond the skin into the nervous and skeletal systems. You palpate along the limbs and may detect firmer nodules along nerve pathways, known as subcutaneous neurofibromas. These are less visible but equally significant. Then there is another form that demands special attention, the plexiform neurofibroma. These are larger, deeper, and often described as having a bag-of-worms texture due to their diffuse involvement along nerve branches. They are often congenital and can grow extensively, sometimes causing disfigurement or functional impairment. More importantly, they carry a risk of malignant transformation, which makes their identification crucial. Now, shifting your focus to the skeletal system, you observe posture, limb alignment, and overall growth. NFON is not just a skin or nerve condition, it affects bone development as well. You may notice scoliosis, a lateral curvature of the spine, or abnormalities in long bones such as bowing, particularly of the tibia, which may even progress to pseudoarthrosis. In some cases, there may be sphenoid wing dysplasia, affecting the bones around the eye and leading to orbital asymmetry. These skeletal findings reinforce that NFON is a multisystem disorder, not confined to one organ system. Now, let us move to the eyes, where subtle findings can carry immense diagnostic weight. Using a slit lamp examination, you may detect small, dome-shaped, pigmented lesions on the iris known as Lisch nodules. These are iris hamartomas and are highly specific for NFON. They do not affect vision directly, but their presence is a strong diagnostic marker. In addition to this, you must be vigilant for optic pathway gliomas, which are tumors affecting the visual pathway. These are typically slow-growing, but can lead to visual disturbances, including decreased vision, visual field defects, or even proptosis. This is why regular ophthalmologic evaluation is essential in patients with NFON. Now, stepping back, you begin to connect all these findings: the café-au-lait spots, axillary freckling, neurofibromas, Lisch nodules, skeletal abnormalities, and you realize that you are not looking at isolated features but at a unified syndrome. At this point, clinical reasoning leads you to apply the diagnostic criteria. NFON is diagnosed when a patient meets 2 or more of the established clinical criteria. These include having 6 or more café-au-lait macules of appropriate size, freckling in axillary or inguinal regions, 2 or more neurofibromas or 1 plexiform neurofibroma. the presence of Lisch nodules, optic pathway glioma, characteristic bone lesions, or having a first-degree relative with NFON. These criteria are designed to ensure that the diagnosis is both sensitive and specific, allowing early identification while avoiding overdiagnosis. And here lies the beauty of NFON. It is largely a clinical diagnosis. You do not need complex investigations in most cases. Your eyes, your hands, and your understanding are your most powerful tools. But NFON does not stop at visible features. As you continue your evaluation, you must also consider the neurological and developmental aspects. Many patients with NFON experience learning difficulties, attention deficits, or motor delays. These may not be immediately obvious during a brief examination, but can significantly impact quality of life. Early recognition and intervention can make a meaningful difference. Additionally, because NFON is an autosomal dominant condition, family history becomes an essential part of the assessment. Asking about similar features in parents or siblings can provide further confirmation and guide genetic counseling. Each child of an affected parent has a 50% chance of inheriting the condition, making family education and long-term follow-up crucial. Now imagine explaining this condition to a patient or their family. You would describe it as a genetic condition that affects the growth and development of nerve tissues, skin, and bones. You would reassure them that while many features are benign, regular monitoring is important to detect complications early. You would emphasize the importance of multidisciplinary care, involving dermatologists, neurologists, ophthalmologists, and orthopedic specialists. And most importantly, you would highlight that early recognition empowers better outcomes. As we bring all these elements together, the clinical examination of NFON becomes more than a checklist, it becomes a narrative. A story told through the skin, the eyes, the bones, and the nervous system. Each finding is a chapter, and when combined, they reveal the full picture of the disease. The café-au-lait spots introduce the story, the freckling adds detail, the neurofibromas bring texture, the eye findings confirm the diagnosis, and the skeletal and neurological features complete the narrative. This is the essence of clinical medicine, seeing patterns, connecting dots, and understanding the patient as a whole. So the next time you encounter a patient with multiple skin lesions, pause and look carefully. Count the café-au-lait spots. Examine the axilla. Palpate the nodules. Look into the eyes. Assess the skeleton. Ask about family history. And in doing so, you may uncover a diagnosis that changes the course of that patient's life. That is the power of clinical examination in neurofibromatosis type 1.